evening, guys. Thanks very much for logging on. I can see my phone's going kind of crazy with people coming onto the website to get onto it. Hopefully that it's now allowing you to actually stream from the website rather than having to go to YouTube. If it's not working, then hopefully everybody's managed to find their way to YouTube. I'm going to try and see whether I can answer questions and things over my chat window in this. So if I'm looking away, I'm not checking my text. I'm just checking to see if anybody's got messages. So let's see. Message me here if working. There we go. Great. Okie dokes. So I'm going to make my window a little bit smaller, and then I'm going to get the slides up at the same time. So the topic for tonight is about knee injuries. Obviously, going to go through lots of different things, not just trauma, but also some details about osteoarthritis and also some other pathologies that we have within our knees, including patellofemoral joint instability. So let's get started. Now, the context of all of this is trying to weave in a little bit about braces. It's something that often as surgeons, we tend not to get super involved with. It tends to be more the physio side, or we send somebody to orthotics. I think it's really important that we understand why we're sending somebody for a brace, or we're asking you as a physio or an orthotist to actually give the patient a brace, and also to be able to give the patient some kind of expectation as to why they're getting their brace and what difference it's going to make. And I must admit, it's one of those things that I've not looked into a huge amount of detail, and I did a bit of a search to try and find the evidence and understand. I know, and you know, that patients do well with certain braces in different circumstances, but is there actual scientific evidence? Can we really understand what it is that the braces are achieving? So a little bit of background about me. I've probably met quite a lot of you guys before. People might know a bit about me. For those that don't know me, I'm clearly not from the South Coast. I'm trained in Scotland, born in Scotland, went to university up in Aberdeen, did most of my medical and orthopaedic training in the west of Scotland in Glasgow, pretty drizzly, made my way down here to Southampton and Wessex to do my fellowship training as a Zimmer Fellow with Professor Barrett and Professor Chapman-Sheath. Been abroad to France to David de Jure. He's the father really of patellofemoral instability and trochleoplasty and the medial patellofemoral ligament reconstruction, something that I'm really passionate about and do a lot in my practice. Also in a major trauma centre here on the South Coast in Southampton General, did a travelling fellowship with Professor Adam Starr in Dallas, Texas, which was absolutely fascinating on a whole different level over there. The adage of everything's bigger in America is definitely true. I'm a major trauma consultant and a knee consultant in Southampton General. So even with our team is so large in the General that I can actually focus more on lower limb and knee trauma, and my elective practice is pure knee. So no hip replacements, nothing like that. So my specific, very focused interest is soft tissue ligament reconstruction, and particularly unstable kneecaps and patellofemoral instability. So that's people with dislocating and painful patellofemoral joints. I also am doing that in adults and the pediatric population. So it's really interesting. There's a massive crossover, and it's actually one of these things, particularly with unstable kneecaps, that it's probably best dealt with when you're younger to prevent you getting all those secondary effect problems such as arthritis. The plan is really to kind of try and simplify the kinds of braces that are out there and their different uses. So I thought it'd be sensible to try and break it down into categories. So we've got kind of preventative braces. Now these are really an interesting topic. It's something that people often come into clinic with a brace on, or tend to kind of gravitate towards it, not necessarily through us or through a physio, but often self-led online, looking up some information, or even just buying a brace in the hope that that helps their knee. So we'll go into a bit of whether there's evidence and use for a brace as a prophylactic device, so it's something to prevent you actually having an injury or getting a problem. We then have functional braces, so that encompasses braces that have a particular protective effect and are trying to resist the forces within your knee, such as an ACL brace to prevent the rotational movement within your knee to protect an ACL, be that one that's injured, one that you want to not injure, or one that's been reconstructed, or that anterior posterior laxity within the knee. So you'll often see that, and people will have seen in a posterior cruciate ligament brace, where there's that mechanism in it that's almost like a spring forcing the tibia forwards, resisting the backward laxity of the tibia and knee without the PCL. Then move on to probably a much more familiar set of circumstances for most people, and me, is really when I get involved in braces is in the sort of rehabilitation phase. So post-operatively, somebody having a brace to resist and protect maybe a reconstruction, or one to allow them to get back to sport. So we'll go through a little bit of that. We've got the obvious kinds of braces that we know about, and then I'll, at the end, talk about some different interesting kinds of adaptations or types of braces that you may never have seen before that might be interesting. So obviously, knee injuries and musculoskeletal injuries are incredibly common. You know, with an emergency department with a population of about 500,000 people, you would expect to see about 600 significant knee injuries a year. Now, that's not talking about somebody who's had a bump or a bruise. This is somebody who has a significant injury that stopped them being able to carry on with whatever they're doing, presenting with an effusion or a hemarthrosis. This is a population that's increasing year on year on year, and sport and the activities that we carry out are a really significant factor in causing those injuries. And people's level of sporting activities and the degree of danger they're putting themselves into is increasing year on year. It's not just simply going to play five-a-side football, it's jumping out of planes, jumping off bikes, being on motorized devices, be them electric scooters or all sorts. So everything's becoming much, much more dangerous, and people are putting themselves in harm's way on a very regular basis. It's my opinion that any knee injury that has an effusion or hemarthrosis or something that stops you in your tracks and actually makes you present to an emergency department probably should be reviewed by a specialist, because there are many things that are just not picked up in that really acute phase, whether it's me or whether it's an ED doctor or whether it's a physio. Within the first 24 hours of somebody hurting their knee, you're not going to be able to examine it properly. They're not wanting to move it properly. Incredibly difficult to identify whether they have a real problem or not. An x-ray may not actually give you that much information, because unless they've done something bony, you're not going to see it. And there are several different injuries that we want to see early and are best treated early and give people the best opportunity of getting back to normal if dealt with early, be that ACL injuries, be that collateral ligament injuries or meniscal tears that are significant. Interestingly, the highest rate of injury is within the 15 to 22-year-olds. Anybody that knows a 15 to 22-year-old, that wouldn't come as a surprise. The majority of them, again, not a huge surprise, are male more than women in that demographic. And 50% of those are from athletic activities, be that football or skiing or whatever. So the other important causes for significant knee pain and disability, so it's not all just trauma, it's not just problems that have happened because you've broken a bone or something like that. We also get people that have osteoarthritis within their knees that cause them pain and disability and difficulty mobilizing. Ligament instabilities, so they may not necessarily be painful, but they've got instability that's stopping them actually carrying out the different activities and things of daily living that they need to do. Meniscal pathology, patellofemoral instability, and it's deciphering throughout all of those when is a brace of benefit to the patient. So do we have any evidence for these things? Oh, myself. So if we're going to look at the preventative side of things and prophylactic bracing, one interesting study that popped out, and one place as per usual that really kind of investigated whether this was useful or not was in the United States. Much higher numbers than we have over here, and in a specific environment that it became very clear was in the NFL. So the National Football League, playing American football, suddenly they changed the rules and it allowed players within the regulations to wear a brace, not just because they've had an injury or not just because a doctor's told them that they have to, but from a prophylactic perspective. So there was a really high uptake all of a sudden of players using braces, and a lot of interest in studies trying to work out whether braces were actually going to prevent these players who are worth a huge amount of money injuring themselves. Also, it gave them an opportunity to sell an awful lot more braces within the industry, and therefore there was a lot of motivation for these studies. Interestingly, despite that, and despite all the money and effort put into it, most of the research and the data produced on braces is very, very poor, very low level evidence. So anecdotal, very difficult to do something like a randomized controlled trial with a brace. As you can imagine, it's impossible to have two different groups and really separate it out. You can't have it blinded. So the data is very limited. What came out of it was a real mix. There was some possible evidence to show that there was a reduction in medial collateral ligament injury, but on the other hand, there were studies that contradicted that and really didn't have a firm decision one way or another whether it did that. Certainly, what it did show is that wearing a brace actually increased the energy demands of the players using that brace. Now, that would kind of make sense if you've ever had a brace on. You can imagine that using and running and moving a brace with a brace on would be very difficult. The other issue is that using a brace, and what came out of these studies was that there was a real sense of security that patients felt having them on, and that was often a false sense of security. So it didn't really give them protection, but it made them feel as if that they were much more protected than they were, and actually potentially put them at a risk of causing another injury. So the bottom line, the American Academy of Orthopedic Surgery came up with, similar to our NICE guidance, to say that they did not recommend prophylactic bracing, not just in the context of the National Football League, but in athletics or any other kind of activity at all. There was no real evidence that wearing a brace actually would reduce your rate of injury long term. What they did show was that actually the things that we all know, that mastering the technique, strength, conditioning, warming up, these were all far bigger players in injury prevention, not a brace on its own. If you are going to use a brace, and this came out with regards to the medial collateral ligament protection, was that the braces really needed to be tailored to the player or the person. As you would imagine, the longer the brace, the bigger the lever arm of that joint, the longer your leg is. Therefore, you're protecting more of it and reducing the risk of that injury to medial collateral ligament. We've all seen patients come into clinics where they've bought something online and they've got this tiny little hinged brace. It's much more comfortable for them, but it's not really doing very much with regards to protecting the medial collateral ligament. I often get quite frustrated. You get patients who are given a proper range of motion brace after a surgery to protect their ligament, and they don't find it particularly comfortable because it's doing what it's meant to do, which is to restrict them. And then they go and buy a little tiny one that gives them a much wider freedom of movement and doesn't really do its job. So if you are going to go down that route of wearing a brace and you want it to protect your medial collateral ligament, it's ultimately important that it's long enough and it actually fits you properly and it's been customized and fitted directly to you. Really important to try different sizes and types. As we know, patients are all different sizes and shapes, legs are different sizes and shapes, and one doesn't fit everybody. So just because one brace doesn't fit or achieve what you want, there may be another one out there to do that for you. Obviously, it only protects you if you're actually wearing it. So if it's not comfortable and you don't want to wear it, then it's not going to help you. So these were some interesting papers that I identified off PubMed, and going through them. What it did show was that yes, if you can resist that rotational movement within your knee, particularly for protecting an ACL, or the anterior posterior movements of your knee, then yes, you could potentially protect your ACL. But what it showed was that no brace actually could resist the forces to the degree that it needed to protect your ACL. So some of them are designed certainly to try and resist those movements, but ultimately are never really going to achieve exactly what we want. This was another one by Robert Laprade, who's a very famous surgeon in the States, who carries out ligament reconstructions and lots of research in ligament reconstructions. And it showed that they had a special dynamic force brace that was putting pressure on. And even then, with all the resources that they had, showed that it may change something if they could actually produce a brace that gave a resistance to physiological forces, but there was no real evidence that it showed that it actually did anything at all. Functional bracing is probably much more in line with what we all understand. It's normally used for post-ligament injury or for ligament reconstruction. The majority of them that we'll use and you'll see will be the kind of standard range of motion type braces, where it's got two metal bars with Velcro and sponge around the top and the bottom. And the predominant thing it's trying to resist is that coronal movement. So the movement side to side that your collateral ligaments would normally try and resist. Again, there are actually very few poor studies showing the evidence of any of this. What it showed was that there was a lot of subjective feedback. So very little objective evidence, but lots of subjective stuff fed back from patients saying that the confidence that they get from it, the reduction in pain that they get from it, or the perception of instability. So it doesn't actually necessarily make them more stable on something that we can measure, but it gives them the perception that they feel much more stable. Before I go on, I'm just going to try and see if I can change the volume on this. I just got a little bit of feedback to say that it's a bit quiet. I don't know if that's any better. So again, studies showing that there's increased energy expended when you're using a functional brace. So something that's trying to resist a certain movement within your knee or push your knee in the opposite direction actually causes you to use more energy and to overcome that in the activity of the sport or whatever you're doing. The compression of the brace on its own round about your muscles, interestingly from one study, showed that there was an increased buildup of lactic acid and ischemia. So yes, it was actually the compression, a bit like a tourniquet around the muscles, that were restricting the blood flow and causing some ischemia within the muscles that increased the lactic acid, that was then having an impact on the ability of you to be able to continue the sport, the activity that you wanted to do at the high level that you wanted to. So, for instance, we would use them in patients like this. This is an ACL femoral avulsion where the ACL had been pulled off from its femoral attachment. We've carried out this surgery. We actually use a brace inside the knee. It's not really technically what we're talking about here, but again, it's the same biomechanical principle of trying to resist the movement that your knee wants to naturally do beyond the capability of the structure inside. So we use a piece of nylon tape, but functionally bracing that sort of patient post-operatively is really, really important, because what we want to do is ideally have a situation that we're protecting that patient from over testing the strength of what we've just fixed back together. The ones that work the best are definitely for the medial collateral ligament and lateral collateral ligaments, but you rob people of that range of motion within their knee often in order to give them that stability, which then becomes a difficult trade-off. So again, even with the functional bracing, probably more than even the prophylactic ones, where you've got a patient who's post-operative, who's got a swollen leg, who's got pain, it's even more important to have a brace that's absolutely fitted correctly to them. You'll often find that braces slip and slide down the leg, and interestingly, again, there was a study that showed that the positioning of the hinge point of the knee actually in the post-operative period or post-recovery when somebody's trying to do some more activity, that if you're wearing a brace and it's not quite fitted correctly and you have a further injury or you have something else happen, it can actually increase the chances of you doing some more harm to yourself, be that of your soft tissues or even causing fractures in some of the patients that they highlighted. The forces needed to prevent tibial translation and rotation exceeded that even of the best functional brace. So I think the majority of the papers and the studies with any of these braces are showing is that it's a reminder to the patient that they have an issue. It's a reminder to the patient that they need to be careful with this limb and they need to use it within the limits of what's comfortable for them. I think they get feedback and proprioception from just even the pressure over the skin, which then gives them that confidence and feeling that they are able to do a little bit more than they would without that brace. There's definitely a huge psychological element of a brace giving patients that confidence. I've seen patients wearing a hinge brace that has no impact on what it is that's going on. So you have patients that have patellar femoral instability wearing a simple hinged knee brace that doesn't restrain the kneecap, doesn't do anything, is completely unlocked and they're bending, and yet patients will absolutely say that without the brace, there's no way that they can mobilize. As soon as you put the brace onto them, they're fine. So there's an absolute element of a psychological crutch in wearing a brace. This is manifested in some of these studies. And again, here's the references if you want to have a look at some of them. They're quite interesting, but it's predominantly the proprioceptive feedback and the ability to be able to carry out symmetrical jumps and getting muscles engaged by wearing a brace rather than the true biomechanical forces that are stopping their knee rotating. So patellar instability and braces in patellar instability, again, it's looking for evidence is tough because there's just not the studies, there's not the patients. This is already a really niche patient cohort. To then get that down to braces is incredibly tough. There's lots of different reasons why people have patellar instability. A lot of them who have chronic instability tend to be hypermobile. There's a family history of instability. They have congenital deformities that have been there or developed over time because of other congenital deformities, such as trochlear dysplasia, where they don't have a patellar a groove within the trochlea at the bottom of their femur to allow their patella to actually run in normally. They have patella alta, so the patella isn't able to engage as early as it should do. They've got malrotation of the limb and the bone, which means that the trochlear groove, the groove that their kneecap should be running in, isn't sitting underneath the patella to allow it to track and is more likely to dislocate. And again, a valgus knee, so somebody with knock knees is got that same problem where the groove for their kneecap is not where it should be and increases the chance of dislocation. Interestingly, there was this paper in a pediatric journal mentioning that first-time traumatic dislocators with fixing them acutely or putting them into a brace actually did well in both. Now again, this is a paper that I would be very cautious of because actually acute surgical intervention for a first-time dislocator with somebody, and it didn't separate out necessarily whether they had lots of other congenital problems such as they were hypermobile or they had trochlear dysplasia, is very, very rare, and it's not something that we would normally do. And actually that patient cohort does really well with physio, and there's a proportion of patients, whether you brace them or whether you don't, or whether you have surgery or anything, will probably have the same outcome. So with any of these things, when you're reading any evidence or any papers, you've got to be very careful about what you're reading and make sure that you really critically analyze it to make sure that what they're saying is actually relevant. So I don't think this paper is particularly relevant from that perspective. So you can see that there are some patients who have such significant problems within their joint that the best brace in the world, it's not going to keep that knee from dislocating. So you've got to choose your winners. There are certainly some patients who do really, really well with a brace, particularly with patellar instability. Again, it's that feeling of proprioception. Patellar apprehension is something that, again, is incredibly difficult to quantify. It's not something that you can put on a scale of 1 to 10. I've got patients that even walking across the room to go and examine their kneecap, they freak out and don't want you to do it because they're so scared that their kneecap is going to dislocate. And I suppose they're on that scale of like 10 or 100. And then you've got other people that have got very lax patellofemoral joints that will allow you to manipulate and move them and have no issues. But patellar apprehension is one of the things that is made better by a brace in a quite significant number of the patient population. And it's very specific braces for this, and you can understand on a more biomechanical perspective as to why that works. So a bit like when we're bending the patient's knee up who's got patellar instability or patellar apprehension, if you put your thumb on the lateral side of the patella and just support it so that they have some feedback, some proprioceptive feedback that their kneecap's not going to dislocate, they will allow their knee to bend quite easily. You take that thumb away, suddenly they feel like it's going to dislocate and they hate it. And what these patellar braces do is they have like a half moon of Velcro, which is pulling the kneecap towards the medial side, putting some pressure on the lateral side and giving them that feeling of proprioception, that security that their kneecap is captured and it's not going to suddenly dislocate. That's really useful in the period of somebody who's got an acute dislocation, perhaps, who's decided to be treated conservatively or isn't in a position to have any surgical management or isn't relevant for them to have surgical management. And that will give them that security and allow them to start rehabbing more. The secondary effect of having somebody who's got a significant patellar dislocation is that they don't bend and use their knee, they don't engage their quads, they get a huge amount of quads wasting, and that compounds itself with all the morphological problems that they have with their knee that's putting them at risk of patellar dislocation. And then you throw in losing even more proprioceptive feedback because they've lost all their muscle bulk. And then they get the secondary instability, which is actually inhibition of their quads anytime they're bending, and they're in real trouble. You give somebody some security of their patella so that it doesn't feel like it's going to dislocate with a brace, and then really engage that physio and work their quads. It's amazing what you can actually achieve in some of these patients without any surgery. The new world that we're living in at the moment, with limited access to elective operating, waiting lists that are getting bigger and bigger. I mean, we have patients, nearly 1,700 patients on the orthopedic waiting list, and you know, the length of time between seeing the patient and then them actually getting their definitive surgery is potentially going to get longer and longer. Having that option of a brace or something that's going to hopefully make them feel more confident and comfortable in the meantime, not lose any more muscle or proprioception that they've already lost already, and also hopefully preventing them from having another significant dislocation that could cause a problem with damage to that articular surface behind their kneecap or in the trochlear groove. So I think braces may well start to play a bit of a bigger role, and certainly in my mind, throughout all of these things, I'm thinking more about the length of time it's going to take for patients to actually come to their definitive surgery, and whether there's anything I can do for them in the interim that will tide them over, or at least make it bearable while they're waiting for their surgery. The most traditional, normal place that we understand braces is in the post-operative period. And again, we often, just because it's a learned behavior that, you know, you put a brace on somebody to protect them, I don't know sometimes whether that's making me feel happy or whether it's for the patient. And it's been interesting doing this to really look and see whether there's a huge amount of evidence for the things that we're doing. Again, it comes down to that psychology, whether it's my psychology or the patient's. It certainly gives you more confidence to allow a wider range of motion and maybe quicker rehab and access to physio, because the patient has that feeling of proprioception and feedback and confidence as to where their limb is. They're learning how to use this limb differently often after they've had a ligament reconstruction. The best analogy I always say to patients is that, you don't ever think about where your limbs are or what the limits of your movement are unless something happens to you. It's a bit like getting a filling in your teeth. You're not aware that your teeth all match and how they feel until somebody changes the tiniest little thing, and then you spend about a week afterwards kind of feeling this weird unevenness in your mouth until you get used to it. And so you multiply that by about 1,000,000 when you've had a ligament reconstruction, you've had surgery in your knee, you've lost all of your quads, and you're trying to use and move that leg normally. It's going to take you a long time for your body to understand where things are, where the limits are again. So, a brace, if that allows that to happen more quickly or in a much safer, more confident environment, then that's absolutely fantastic. Clearly, there are some things that we do that absolutely make sense that need braced. Again, going back to somebody who's had maybe a significant medial collateral ligament injury and it's been reconstructed to that coronal stability by giving them a hinged knee brace makes perfect sense. Interestingly, I use it quite a lot for patients that have patellar instability surgery, and we do a tibial tubercle osteotomy. So that's where we take the attachment of the patellar tendon onto the front of the tibia and we realign it to make sure that their patellar tracking is much more normal. That piece of bone, a bit like a fracture, needs to heal, and they need to take some of the pressure and stress off that for a short period of time just to allow the soft tissues to heal and also to prevent that being moved or pulled inappropriately. So restricting their range of motion in a range of motion brace is what we do. And again, that surprisingly doesn't have a huge amount of evidence, and there's not a huge amount of evidence to show that we're actually changing the forces or the pressures between that fracture fragment, but it makes sense in my mind as to why we're doing that and protecting that fracture or that osteotomy. One thing that I would point out that's kind of relevant to this, and you see quite a lot, we see it in trauma where people have a patellar fracture and patients will be put into a cricket pad splint or into a range of motion brace and they're told not to weight bear. So not weight bearing actually increases the force within your extensor mechanism, because trying to move and use your leg without bending it and without putting weight on it, it causes you to have to engage your extensor mechanism that puts more pulling force across your extensor mechanism, your patellar fracture or your tibial tubercle osteotomy. So it's really, really important if you see patients like that, that you allow them to weight bear, as you're actually reducing the forces within the joint and the extensor mechanism. Another good place that I've seen braces used are for anterior knee pain patients. So these are the patients that are on that instability spectrum who maybe don't necessarily have frank dislocation of their kneecaps, but they may have maltracking of their patellae that are causing pressure problems or anterior knee pain. A really difficult cohort of patients to treat often, particularly if it's very subtle changes. That step up and jump to then doing something much more extensive, such as an osteotomy, it may not be appropriate. And using a brace, in particular one of those patellofemoral braces that can put some lateral pressure in the patellofemoral joint, might just be useful in giving them that confidence and taking some of the pressure off their kneecap. You certainly don't have a huge amount to lose in trying something like that, and it's one of those circumstances that I'm not really sure that it matters if there's any real evidence for it or not. A bit of trial and error for something that's not a particularly expensive brace, if it gives the patient what they want with minimal risk, then that's absolutely fantastic. Bracing and osteoarthritis, kind of the last topic that I'm going to broach tonight. Offloader braces, again, it's not something I've used an awful lot of, and the climate now and the waiting times and everything else, certainly it's something that's come to the forefront of my mind as to whether there's actually some evidence and benefit in using them. Again, clearly the mechanism makes an awful lot of sense. I was never very sure whether the forces that you can apply through this, which is a functional brace as we've learned before, is enough to actually have a significant impact on their osteoarthritis, or again, is it more the pressure effect, the proprioceptive effect, and the limitation in the movement in their leg that you're getting the benefit of a brace like this, or is it truly distracting the joint and actually doing something to worn out joint compartment, be it the medial side or the lateral side. Obviously, it's not suitable for patellofemoral osteoarthritis. There's no way of offloading that through a brace. But the aim of it, as you can understand, is to have an opposite opening force, whether that's a varus force or a valgus force, to distract and pull that joint that's worn apart, and also to help with the alignment of their leg. These are obviously the simple things that people understand, that why you get osteoarthritis, you know, whether it's post-traumatic, whether it's after a degenerate, after a meniscal tear that's needed to be removed, a ligament injury that's left them with some instability. I'm not going to go through the kind of, everybody knows what osteoarthritis should present with that pain, the deep pain, etc. If there's any concerns and you don't have an x-ray and you've got somebody with chronic pain within their knee, it's really important that you either refer them or you get an x-ray. So that's a quick aside. But management-wise, conservatively, I've always just thought about activity modification, which is number one, taking some regular painkillers. Number two, topical anti-inflammatories are useful, and weight loss is obviously really, really important, because it's just physics. Reducing the pressure across the joint will help with their pain, but often the most difficult one to convince patients of. So unloader braces, these were the actual evidence in the papers, and it was really interesting to watch one in gait analysis that using an offloader brace actually opened up the joint compartment that was being the force was being applied across, which is really, really interesting to see that unlike some of the other functional braces that we saw for anterior cruciate ligaments, is that the forces that can be applied by these braces actually can have a real impact on the patient's joint. And another one there where there was a valgus unloader brace on patients that had a previous meniscectomy, which then obviously reduces the volume within the joint and gives them a change to their overall alignment, which then sort of snowballs that effect of wearing out their cartilage and changing their long leg alignment. The brace actually did have an impact on that. So that's really encouraging from my perspective in understanding how these work, and is changed what I would do. And I would genuinely try an offloader brace, where before it's not something that I really considered. These are obviously the other things that we can deal with once you've gone through that conservative management phase and stepping up the ladder of invasiveness: steroids and local anesthetic, hyaluronic acid, PRP, stem cells, lots of different names for that kind of treatment. It's not something that there's a huge amount of evidence for, and I'm sure it's something in the future that's going to be of benefit, but we really don't know what thing for what pathology. So I'd be very cautious about referring any patients for any kind of biologics at the moment. Microfracture for very focal chondral injuries rather than osteoarthritis really doesn't have a place in osteoarthritis. And there's new focal implants that are being developed and thought about. We're desperately trying to get a study up and running, given the situation with COVID, into what's called the EpiSurf. So that's for small custom-made focal implants for knees made out of metal. And it's something that we're doing a study on. So if there's any patients that you know that could fit into that category, we'd always be really interested to hear once we're up and running. But it's not something that we do routinely. Obviously, the next step up from an osteoarthritis perspective is going to do something which is a total knee replacement, which is ultimately resurfacing the whole surface of the joint and of the tibia. Partial resurfacing. This one here is a partial medial uni arthroplasty, where we're resurfacing the worn out medial condyle and the top of the tibia, but leaving the ACL, the PCL, the patellofemoral joint and the lateral joint compartment where that cartilage is good. And what we're doing is returning the knee to the alignment that it should have been in the first place, and hopefully preventing any kind of progression. Understanding that partial joint arthroplasty is not something that's an interim procedure. It's not for young patients. It's for patients that have isolated arthritis, who have evidence that the rest of their knee is good, and it does incredibly well in the correct patients, and gives them a knee that feels much more like their own knee, just without arthritis. And it's something that should last just as long as a total knee replacement. And depending on the age that that's done in, we would expect it to be the only operation that they have in their knee. So I think there's a bit of a misconception with regards to unicompartmental knee replacements, and it's just to kind of tidy that up a little bit. Another option is realignment osteotomy, and that's rather than putting something in the knee to resurface it or to take away that worn out joint compartment, is to actually take somebody who's clearly overloading one part of their knee joint and then realigning things to take that pressure off and give them a knee that functions much more normally. Now, this is a lady that's obviously very valgus and who's putting a lot more pressure and causing degeneration in the lateral side of her knee. And what we've done is we've done a distal femoral osteotomy to realign things. And you can see that green line represents her weight axis coming down through the middle of her hip to the middle of her ankle. And we've changed it from all that weight and pressure on the very lateral edge of her lateral tibial plateau to down the middle of her knee, and spreading that weight and pressure out over the surfaces that are good, that aren't worn. We do the similar thing with isolated lateral patellar arthritis, where you can do an osteotomy and move the extensor mechanism in the patella to allow it to track off that. So there's lots of ways of dealing with offloading an abnormally loaded joint without bits of metal and plastic. This was just an interesting thing, and this kind of fits in with the offloader type braces. Now, the brace, although we've got some evidence to show that it can open up a joint when you're walking and you're taking weight off it, that might improve your symptoms. This was a study that was done that rather than trying to replace the joint or to do an osteotomy, they put an external fixator, a bit like you use for a fracture, on the outside with pins, and actually pulled the joint apart for a period of time and took the pressure off for a long period of time within the joint. And interestingly, that showed that it increased the amount of visible cartilage within the joint. Whether that actually caused cartilage regeneration or whether that allowed the cartilage to become healthier and to rehydrate itself where it's been under pressure for a long period of time, I don't know. But it's a really interesting study that isn't something that's done routinely, but it's an interesting scientific point to show that clearly pressure across a joint has a very significant impact on the way that your cartilage acts. And actually the fact that reducing that pressure and force across your joint may actually allow cartilage to regenerate, or at least to get as close to back to normal as it possibly can. So it's a really interesting thing that may reap some interesting results in the future, but it's just something I'd put out there that kind of fitted with that offloader brace concept. This is another one that's not technically a brace. I'm not sure I would categorize it completely as a brace, but this is called the Ski Mojo. Disclosure, it's got nothing, I have no financial benefit from flogging the Ski Mojo. This is something that actually patients came to me telling me that this is a thing that they've used and they think it's fantastic and I should tell other people to use it. Again, I'm inherently quite skeptical with anything like this. You know, there's a worry that there's an element of snake oil in lots of stuff that's marketed. This was used by Shemi Alcott, who's the British skier that injured herself, and she used this in her rehab. And the concept of it is that it offloads your weight when you're trying to ski by about 40% is the numbers it gives. I'm not sure it's 40% necessarily. And the aim of this is if you've injured yourself and you're getting back into skiing, that it takes the pressure off your joints. Or if you've got pain or problems with your knees, or you've had trauma, or you've had something else that's causing you pain, that this takes off some of the pressure. So it's like magically lightening you by 20 to 30% of your body weight when you're skiing, and allows you to do it for longer than you would normally. So I didn't really believe how this worked. Contacted the guy that owns the company, who came around and actually put one of these onto me in my living room. And it's really quite amazing. And I had a patient recently who's actually on the Ski Mojo's website, which I discovered today, who's our very own resident surgeon in the general. I'm not going to mention his name in case he doesn't want me to mention his name, but I'm pretty sure it's actually on the website if you go and have a look. But again, he was a devastating tibial plateau fracture while skiing, and within the year managed to go and ski for 3 weeks by using this. So, I mean, that's pretty impressive and a good endorsement of it. And I got direct contact with this person. I was very impressed that they managed to ski for 3 weeks within, I think it was even 9 months of a tibial plateau fracture that required an open reduction and internal fixation. So there you go. So I'm going to leave that up. I'm going to have a quick look at my phone and see whether we can... yeah, so I'm just going through some of the messages. Lots of people saying I was very, very quiet. I apologise. I hope you could hear something. Denise Ferguson, where can we obtain these types of braces for patellar instability or medial collateral ligament tears? I'm in primary care. So the one that I've come across, and it's probably the most frequently used one that I've ever seen, is the company DonJoy. I'm sure most people that have got anything to do with knees or musculoskeletal stuff will have heard of DonJoy. And it's the lateral J brace. And it's a relatively inexpensive brace, and it's got a Velcro bit that goes around your kneecap. So that's one to look at. The other person here, the other quick question says, what do you think about K-taping instead of a brace? So this is one that, again, I've been very interested in because it was very popular for a while. You saw lots of people with sort of physio tape and K-tape. Again, from a purely mechanical surgical perspective, there is no way that sticking tape on your skin, no matter the kind of pressure that you can apply on it, can deviate your kneecap or change the mechanics of how your knee works. That may be a really controversial thing to say, but there's no way that the forces going through your knee can be resisted by tape stuck to your skin. However, much like the evidence that we've seen tonight with a lot of other braces, is that what it does provide is a feeling of feedback, proprioception. It alerts the patient as to where their kneecap is, and I presume depending on where that tape is applied and the configuration that tape is applied, then depending how they're moving, it tugs on your skin in different ways, and is, I think, a surrogate proprioceptive feedback that you maybe have lost if you've got patellar instability. So I'm not saying that it doesn't do anything. I just think that it's not physically restraining you the same way a brace would. So I'm sure there's certain circumstances that things like physio tape would be much more useful. And I think in patellar instability and anterior knee pain, that's probably one of them. But it certainly wouldn't be able to resist kind of significant forces of any kind of ligament. So, you know, ACL, MCL, that sort of thing. I don't think there's any place for physio tape or K-tape. Are there any other questions anybody's got before I let you go and enjoy the rest of your evening rather than listening to me droning on? So I'll take a few more minutes and just see. Oh, here we go. Do you have any preferred offloader braces? Again, not particularly. I think as we've gone through this, the best thing you can do is to have a brace that fits. So, you know, I think trying to restrict yourself to maybe one brand is not helpful. I think going with one that's good quality. I think you can be lulled in online now to just go and buy the cheapest thing that there is. I don't think that's a good idea either. You know, stick to well-established brands that have got good support. So if it's the wrong size or whatever, you've not suddenly just wasted. These braces are not cheap, particularly if you're self-funding this and buying it yourself. You know, an offloader brace may be £200 to £600 depending on where you buy it. And if you buy that and suddenly realize that it doesn't fit, it's just going to spend its time in a cupboard or under the bed, then you need to buy it from somewhere reputable that you can contact them and have that returned. We've got a link with DonJoy through the site, both the kit room and on the Wessex Knee, and any braces are bought kind of directly with them. And what that means is that if there's any problems, you just return it directly to DonJoy and they deal with it. They'll do a Zoom fitting and explain how it all works. You know, once the world opens up again, if you buy a brace included within that, it's they're able to come out to your house and actually fit it for you. So you're not just going blind buying a brace off Amazon. So that's one option. There's lots of other places that you can buy these things as well, but stick to very well established brands would be my takeaway. So thank you very much, guys. If anybody has any questions that are not asked through this on the chat, just email me. You've got my email address, or you don't have my email address, but you've got the website there. The email address and contact forms are all on the website. Like I said, the kitroom.shop is our kind of link to the DonJoy braces. So if you need anything like that, just have a look on there. One other thing that through the website, and kind of with any kind of knee problem, if there's ever a situation that you feel that it's not been imaged correctly or whatever, then an MRI scan is probably the gold standard for doing that. We've also got a link with Alliance Medical and can do self-referred MRI scans. Either the patient coming directly to us can do that, or a referral from a physio or a GP or anybody that wants to be able to refer that. And that can be arranged within about 3 or 4 days, and for about £260 for an MRI scan of your knee. So if there's anybody that's ever worried about what's going on, that's an option and a possibility. Just need to get in touch with us. So if there's nothing else just now, thanks very much. And I hope if we do something like this again in the future, it all works out, and I'll try and be a bit louder next time. All right, thanks very much.